Hello, everybody. I'm Marie Tolarova. I am pediatrician and medical geneticist. I serve as a president of International Cleft Lip and Palate Foundation. I also founded and presiding a Cleft Prevention International Foundation. I am with Rotaplast International for 30 years. I did over 50 missions all around the world. My daytime job is in academia. I am professor and executive director of Pacific Craniofacial Team and Cleft Prevention Program at the University of the Pacific Arthur Ardugoni School of Dentistry in San Francisco, California. I have a privilege to participate in the Rotaplast Global Scholars Program with series of lectures in which I would like to share my experience and knowledge with Rotaplast Global Scholars and with medical and dental professionals, also with dental and medical residents who are involved or plan to be involved in care of children and adults affected with cleft lip and palate and craniofacial anomalies. This program was designed for local medical and dental professionals and for medical and dental students and residents, and will provide you who are participating in this with an opportunity to learn more about cleft lip and palate and craniofacial anomalies. It will also allow you to observe and participate in activities which are related to Rotaplast cleft surgical missions. It will give you an opportunity to discuss and talk one-on-one with medical personnel during the mission. Will enable you to use the knowledge and experience which you will gain to provide treatment and care for individuals with cleft lip and palate and craniofacial anomalies in your own country. My clinical experience with cleft lip and palate patients with non-syndromic and syndromic ones is based on several thousand of individual children and adults, which I examined, diagnosed, managed their treatment plan, and also included them in research toward understanding etiology and prevention of cleft lip and palate. In my lecture, in three parts, I would like to cover most important topics which you need to understand if you are treating patients with cleft lip and palate. In first part, we will cover classification, diagnostics, craniofacial embryology, and prevalence. In second part, we will focus on etiology and heritability, and also on risk of occurrence and recurrence. And finally, in last third part, we will go over the treatment and prevention of cleft lip and palate. So let's start with first part. We will cover classification of cleft lip and palate, diagnostics, craniofacial embryology, and prevalence. Let's start with classification. The very first classification to any birth defects is whether a defect is isolated or if it's a part of a complex of congenital anomalies. It may be multiple congenital anomalies or it may be part of the syndrome. The second is on which side defect occurs. Is it on left side, is it on the right side, or is it bilateral? The third one will be severity. Is it minor, minimal, microform? Is it mild? Is it severe, etc.? And fourth one, other important variables of classification are regarding of affected individuals as sex, ethnicity, social economic status, birth order, etc. So for orofacial clefts, which include cleft lip and palate, cleft palate or cleft palate alone, atypical facial clefts, and sequences, will be division into isolated anomalies, or sometimes we call them non-syndromic clefts, and this include also atypical facial clefts or Tessier clefts, sequences, which most common one, Robin sequence and holoprosencephaly sequence, and into multiple congenital anomalies. It will be multiple congenital anomalies on known etiology, which will be syndromes, Apert syndrome, Cruzon syndrome, velocardiofacial syndrome, Van der Voort syndrome, and so on. And those multiple congenital anomalies of unknown etiology, which will be multiple congenital anomalies or complex of multiple congenital anomalies. So isolated anomalies, non-syndromic cleft lip and palate, form approximately 65 to 70% of all orofacial cleft. And multiple congenital anomalies form rest of this, 30 to 35%. Our next topic is diagnostics. There is nothing more important than correct diagnosis. Let's go over some important points for diagnostics. Diagnostics of congenital anomalies is based either on morphology or etiology, and sometimes, of course, these are overlapping. So for orofacial clefts, cleft lip and palate, and atypical facial clefts and sequences, we see isolated anomalies, which also are known as non-syndromic orofacial clefts, divided according to morphology and according to etiology. Based on morphology, we will have cleft lip and palate, cleft palate, left, right, bilateral atypical facial clefts, and based on etiology will be mostly sequences. Robin sequence and holoprosencephaly sequence are the most common one. And for multiple anomalies, where cleft is part of that complex, are either syndromes or multiple congenital anomalies. So based on morphology, we have craniosynostosis syndromes like Apert, Cruzon, then we have velocardiofacial syndrome, Treacher-Collins syndrome, Van der Voort syndrome, and so. And based on etiology are mostly environmental syndromes like fetal alcohol syndrome, rubella syndrome, and also those which are caused by mutation of specific genes, ectodermal dysplasia syndrome, association like oculoauricular vertebral spectrum, and others. So multiple congenital anomalies can be either known etiology, and these are those which I described just recently, but also many of those are still of unknown etiology. Let's also include here prenatal diagnosis of orofacial clefts. So while cleft lip can be diagnosed prenatally in developed countries pretty much in 70-75% by ultrasound as early as 13 weeks of pregnancy, even most of them will be diagnosed a little bit later. Diagnosis of cleft palate is still challenging, can be diagnosed in 3D or 4D in the second trimester of pregnancy. But it's improving, and in some places are even close to 80-85% of correct diagnosis of cleft lip prenatally by ultrasound. So let's look at some pictures from ultrasound. As I mentioned, in the US and in developed countries, about 85% of cleft lip can be diagnosed in second trimester. So on the left side, you can see pictures from 2D ultrasound, and this is the baby or fetus with bilateral cleft lip. You can see also protruding premaxilla, very typical profile. On the right side, you can see ultrasound pictures from 3D ultrasound. And again, you can see corresponding picture of baby after birth. And on the top picture, it's probably, correct diagnosis, which was done just incomplete cleft lip. The baby didn't have cleft palate. Actually, on the second picture, when we see collapsing of the nose on the left side of the baby, the child has a cleft lip and palate unilateral. So again, 3D ultrasound, it's really helpful, especially if we are trying to diagnose cleft palate. 4D ultrasound is used as well. It's pretty much, movie actually, and can help with diagnosis of cleft palate as well. In some cases, it may be indicated MRI. In some syndromes, of course, we can do amniocentesis and karyotype and CVC, also in some metabolic conditions which we may actually expect. So let's look at a few more pictures from ultrasound, from very nice publication by Smerius and colleagues. When we see picture prenatal or 3D ultrasound, then right postnatal and post-surgery on cleft lip and palate unilateral, and bilateral cleft lip and palate. Very nice results and very nice diagnosis. So let's look at pictures of children with cleft lip. We can see different severity and also left or right side affected and bilateral clefts. On the left upper picture, you can see what we call form thrust, or sometimes it's called intrauterine healed scar. It's actually clefted orbicularis oris, and connection is only by skin and by mucosa. Surgery needs to be done in order to correct that. You can see of these two on both sides, that bulges which are end of orbicularis oris. The second picture is incomplete cleft lip. There is no cleft alveolus in this patient. And the last one on the top is actually complete unilateral cleft lip and alveolus. Palate is intact. And on the lower picture, you can see bilateral cleft lip and alveolus. On the pictures, when we see also a profile of the child, you can see typical protruding premaxilla. Palate is intact, and that premaxilla, which is protruding, also, will present a difficult situation to put premaxilla in between the segments, which are probably close to each other. And on the right side, you can see also a child with bilateral cleft lip and alveolus, where premaxilla is severely deviated. In the cases like this one, probably, especially the case on the left side, when we have a young child, young baby, NAM will be definitely very useful. And on this slide, you can see again different severity of clefting in patients with a cleft lip and palate. Mild relatively in the boy on left side, and more severe in the girl in the middle, and then intraoral where cleft lip and alveolus and palate goes all the way through in unilateral cleft lip and palate cases. And then on the lower, you can see bilateral cases, bilateral with different, again, the shape, little deviated premaxilla on the middle picture in the patient, and then intraoral of a complete bilateral cleft lip and palate, the most severe case of typical cleft lip and palate. And finally, isolated cleft palate or cleft palate alone. So very, very important. Very important is diagnosed correctly. You can see different type of shape of cleft palate. First two pictures are typical V-shaped cleft palate. Then you see U-shaped cleft palate in a patient with Robin sequence. And then finally, this is the typical picture of cleft palate, which we are seeing in Apert syndromes and also in patients with mid-phase hypoplasia. And on the lower pictures, you can see very clinically important diagnosis of submucosis cleft palate. Many times is overlooked and non-diagnosed in time, and sometimes when a child is having problems at school with speech, then we figure out that there is a cleft uvula and also the clefting which goes submucosally through complete hard palate covered only with mucosa. So we have submucosous cleft palate, which needs, of course, a surgical correction. A very good diagnostic tools is if you see the patient with cleft uvula, you can palpate with your index finger, starting behind upper central incisors and follow down where sutura palatina is supposed to be, and you will actually palpate the sharp tip of that triangle which I draw on this picture. Again, very, very important. So again, please make sure that you press your tongue blade down all the way that you see end of the uvula, because otherwise you really can miss this. And this picture, you can see different types of Tessier or atypical clefts. Paul Tessier, I will be mentioning this later. Paul Tessier, which was a French plastic surgeon, developed classification, these bizarre different facial cleft, which does not correspond to embryological processes, which we are kind of familiar with typical facial clefts. It's a classification on the right side, which you can see. He actually classified them on soft and bony cleft, and classified them in 14 numbers. So let's go now for practical use of correct diagnosis. It's during the first day of the mission. Correct diagnosis is critical. Correct diagnosis is important for decision regarding of treatment plan and regarding of surgery, in our case, in surgical missions. So first day is triage, is selecting patients for surgery, selecting patients for surgery which will be done during the mission. So we have a flow which is standard after registration and vitals. Medical specialists are seeing each patient, plastic surgeon, anesthesiologist, pediatrician, genericist, and dentist and orthodontist. We use dot system. We have green dots for surgery. It means eligibility for surgery. Blue will be maybe surgery. Red will be no surgery. Each specialist must approve patient that is selected for surgery, and any of them can override eligibility for surgery recommended by others. So correct diagnosis is critical. During physical exam, we state and diagnose type of cleft, and we describe dysmorphology, which will lead to a surgical decision. The same type of cleft lip, may be different in different patient, and it is different. So again, surgical decision will be actually modified accordingly. In babies and growing children, be aware that if there are missing structure or hypoplastic structure, usually unilateral, they usually grow slower and unaffected parts are overgrowing. Another anomalies which will help us for differential diagnosis of syndromes. Common associated anomalies with clefting are congenital heart defect, very important because we are putting the baby under general anesthesia. Ear anomalies, preauricular tags, help us with diagnosis of hemifacial microsomia, oculo-auricular vertebral spectrum. You see the picture on the slide. Hypospadias, very important. Syndactyly and polydactyly. Spina bifida occulta, rare, but also may be part of schisis association. Medical history. Medical history, differential diagnosis of systemic diseases, syndromes, also history of previous surgical procedures and previous general anesthesia, allergies, of course. And again, you can see on the picture, baby which I am holding, which has Pierre-Robin syndrome. Again, we have to be very careful with diagnostic. Yes, there is cleft palate, but cleft palate is usually used for airway in these cases. So again, we may consider postponing cleft repair on children like this one. Family history of clefting, of course, can help us again with correct diagnosis. We may see lip pit syndrome presenting only with clefting, without lipids of lower lip, or vice versa, with lipids on lower lip, but also with clefting in other relatives. We have to pay attention of submucosis cleft palate as well. Um, on any complication during anesthesia in the family. Malignant hyperthermia is autosomal dominant condition. So we need to ask the question regarding of general anesthesia and complication in first degree relatives. So let's now talk about syndrome. Syndromes in which orofacial cleft lip, or cleft lip and palate, and isolated cleft palate are part of the complex which is well defined. So, as we mentioned before, these multiple congenital anomalies, these syndromic ones, form about 30 to 35%. So it means they are very common. You may not be able to diagnose exactly the sum of these syndrome, but you should be able during physical exam and evaluating the patient, be able to see that something is not completely the same as for patients with, non-syndromic isolated cleft. So let's talk about first those which are part of the isolated anomalies, and these are sequences. Yes, they don't form a really big proportion of isolated anomalies, isolated cleft anomalies, but they are very important clinically. So Pierre-Robin sequence or Robin sequence has classical triad, micrognathic and retrognathic mandible, airway compromise, which is relative to macroglossia, and U-shaped cleft palate. So may occur with cleft palate and may occur even without cleft palate. So they are also isolated Robin sequence, and Robin sequence which is part of the syndrome. Most common will be autosomal dominant monogenic Stickler syndrome. So they are non-syndromic ones, are deformation etiology in most of these cases. They have no recurrence risk for offsprings, and in about 70% of Robin sequence patients, the small mandible, which is really a cause of airway issues because the normal size of the tongue is obstructing the airway, we may actually catch up in growth. So we are usually postponing palatoplasty in cleft palate of patients with Robin sequence because we may actually observe catch-up growth later. So we need to take care of airway positioning the child, and also, you know, in very severe cases, we may actually perform distraction osteogenesis. But again, correct diagnosis is critical. And another sequence which also goes to the category of isolated anomalies is holoprosencephaly sequence. Holoprosencephaly sequence again is clinically very, very important. It means actually that in the face we are missing or have hypoplastic midline structures. It could be only hypothyroidism, it could be midline cleft lip, it could be hypoplastic nasal bones or missing. It may be, you know, missing one or two upper center incisors or very tiny ones, missing premaxilla in severe cases. And what is critical that this actually sequence may signal that appearance in the face may signal that there is no complete separation of hemisphere. That's why the term holoprosencephaly. And this, of course, as malformation of the brain, will be very risky situation in anesthesia and in, of course, treatment of that patient. So has been very carefully evaluated. So while in isolated cases, cleft lip with or without cleft palate and cleft lip and cleft palate alone are not seen together in pedigrees because, you know, cleft lip with or without cleft palate and isolated cleft palate are pretty much two different congenital anomalies. So when we are seeing them in close relatives, in the same family, in the same pedigree, we always need to consider syndromic cases. It's really, really very important observation. So again, with these multiple congenital anomalies, some of them will be known and syndromic, some of them will be unknown etiology. Chromosomal aberration goes into this category. Of course, it will be Down syndrome, Edwards syndrome, Patau syndrome. We are seeing in our mission probably only Down syndrome cases, and it may have cleft palate, because these two others are very severe and usually don't survive so long. Monogenic syndrome. Most of these will have autosomal dominant inheritance. Smaller proportion may have autosomal recessive and X-linked inheritance. Lipid syndrome will be most common one, which is Van der Voort syndrome in other name, and also overlapping with popliteal pterygium syndrome. You can see the picture on the slide here. Lip pits syndromes are seen nicely if it's not actually corrected. In some cases, we may have also surgically corrected them. These patients is again autosomal dominant inheritance and known combination of different type of cleft lip and cleft palate in very close relatives, which we can see them. What is characteristic which we should pay attention to? It's usually they actually have compromise healing, so we have to be very careful with these patients. Treacher-Collins syndrome, very common. Also monogenic, autosomal dominant. We have hypoplastic zygomatic bones, anomalies, and it's pretty much easily diagnosed, but may occur in different severity. Usually they have a cleft palate, and also most of them may use that cleft palate for airway, so again we may postpone palatoplasty in these patients. You can see also cases on this slide. Craniofacial syndrome or DiGeorge syndrome. It's actually microdeletion on chromosome 22 and may have part of this conotruncal heart defect. Again, very important because of that heart defect. They also have hypotonic face, they have T lymphocyte deficiency, and this is also important for healing. You can see pictures of these children on this slide as well. The George syndrome, it's overlapping, is actually hemizygous deletion of 22 chromosomes. They have short stature, they have hypocalcemia. We sometimes call them catch-22 because cardiac defect, abnormal face, thymic hypoplasia, cleft palate, hypocalcemia, and 22 chromosome. A large group of ectodermal dysplasia syndrome, again, monogenic, autosomal dominant, recessive, X-linked, which is important for us, of course, correctly diagnosed, because some of them may be hypohidrotic forms, and they may have actually risk during the anesthesia as well. So craniosynostosis syndrome, it's a large group, very, very common. We have very successful surgical repair of those, so many of them do have children, and then anomaly is passed to other generation, autosomal dominant. And we have association. Most common will be again oculo-auriculovertebral spectrum, where hemifacial microsomia and golden hair syndrome are part of this. You can see again on the picture. And then we have environmental syndrome, which I mentioned before, fetal alcohols, rubella syndrome, thalidomide syndrome. In cases like that, of course, it's very, very important history during the pregnancy, which may help us with diagnosis. Relatively very common are in our clinic during the mission craniosynostosis syndromes. Craniosynostosis is defined as the premature partial or complete fusion of one or more the cranial sutures. They have characteristics facial features, which may be ocular hypertelorism, proptosis, beaking of the nose, and midface hypoplasia. They may have etiology of both genetic and also environmental. Very common prevalence is about 1 in 2000, 2,500 births. Most of these are affecting sagittal sutures, about half of those. And again, a sign and symptoms is abnormal shaped head, facial dysmorphology, and a risk of these is actually increased intracranial pressure. So that's why these patients need release of the premature synostosis in very early age. Non-syndromic are about 70%, but the 30% of syndromic ones are with very strong heredity, usually autosomal dominant, and they have specific mutations of fibroblast growth factor receptor genes, 1, 2, or 3, sometimes twist, and other genes. Some of them may be also autosomal recessive, but most of those will be autosomal dominant. Apert syndrome is very common. Apert syndrome is characterized, in addition to these cranial sutures, also with syndactyly. In severe cases, maybe like a spoon syndactyly, which only a thumb is actually free. They have very characteristic cleft palate and formulation of the palate, and also they are using cleft palate if they have it for airway. Crouzon syndrome is another one which is very common and which is also autosomal dominant. Its characteristics with kind of shallow orbit and proptosis, bulging eyes. Sieter-Chosin syndrome, another one which has facial asymmetry, and Pfeiffer syndrome, also common one which has large thumbs on large thumb and low big toes also. So finally, at the end of diagnostics, let's point out several red flags which are critical to be aware of if we are recommending patient or making eligible for surgery for cleft lip and palate. Number one is airway. Anything that compromises or may compromise airway is red flag. Any patient with midface hypoplasia may have compromised airway. Any patient with hypotonia, any kind of hypotonia, velocardiofacial syndrome is one of them, may again have issue with airway. Pierre-Robin sequence is classical because we have micrognathic, retrognathic mandible, and normal size of tongue, which is obliterating airway. So we need to position the child, we need to take a lot of precaution, and also consider postponing palatoplasty until either we see catch-up growth or maybe we can place an obturator and then train the patient to develop the nasal airway, not to use the cleft for airway. Number two is bleeding, blood loss. So that's the second red flag. Anything that may have risk of excessive blood loss during the surgery, bleeding disorders, large U-shaped cleft palate in Pierre-Robin sequence, or any older patients or adults for cleft palate surgery may have more blood loss than we have in young patients. That's why we have to order blood. Developmental delay. Developmental delay is definitely red tag because it may be associated with brain abnormalities, may cause seizures, may have reaction to any kind of procedure, and surgical procedure is one of those most risky ones. Developmental milestone in babies, it's very important to follow and give us picture about possible possible developmental delay, which may be due to brain abnormalities. School performance in school children, again, is very good to follow. And educational level in adults. So pay attention to all of this. And the fourth one will be any deficiency of midline facial structures, may be associated with incomplete separation of brain hemisphere. As I mentioned, it will be more severe cases holoprosencephaly sequence, but may have minor facial structures, just hypothyroidism, just missing one of both upper middle incisors, a tiny or missing nasal bone. So again, it needs to be really taking in consideration and really make sure that none of these red flags are a way of eligibility of patient for surgery. Many times you will hear the question from your patients or even from your colleagues, when actually cleft start, when cleft lip start, when cleft palate start. And in understanding to this, you really need to know craniofacial embryology. We can distinguish 5 principal stages of craniofacial development. It will be germ layer formation, neurotube formation, origins, migration and interaction of cell population, especially neurocrest cells, then formation of organ system, and then final differentiation of tissues. Development of the face starting very early, at first week of gestation. We distinguish 3 periods of prenatal development. First period is proliferative. It's only 1 and 2nd week. And then most important one, most sensitive to any kind of disturbance, is embryonic period or organogenesis or morphogenesis, which start in 3rd weeks and go to 8 weeks of embryonic development. Sometimes in some literature you may see until 9 weeks. And then we have last period, which we call fetal period, which start from 9 weeks and go to the birth. If you look at the picture on the slide, you can see how embryo looks in 6 weeks and how it looks a week later. So that's very short time is needed for these processes which are forming face to actually get together and form the face. We can, during the prenatal development and during especially the beginning of prenatal development, distinguished certain clinical correlate corresponding to development stages. During the first week, we can clinical correlate will be infertility, contraceptions, assisted reproduction, and then from congenital anomalies, it will be chromosomal non-disjunction, trisomies, monosomies, which will be, those with cleft, which we discussed before, Down syndrome, Edwards and Patau syndrome. Then we have 2nd week. So during the 2nd week, clinical correlate will be basic pregnancy test. And also ectopic pregnancy. Week third and fourth will be neurulation. This is the time when neurotube defects start actually to develop. Week fourth will be nasal placodes. Week fifth will be medial nasal processus fusing with maxillary processus. Maxillary maxillary nasal processus merge into intermaxillary segment. And week 5 to 6, will be cranial nerves, development of tongue, pharyngeal arches, and so this is the timing when we can actually place cleft lip and alveolus. So cleft lip and primary palate will actually start at this time. It's a failure of merging of medial, nasal, and maxillary processes. And then we have week 6, which are pharyngeal arch cartilage, external ear, and then clinical correlate will be hemifacial microsomia, microtia, trichocolin syndrome, viral cardiofacial, and DiGeorge syndromes. And then we have week 7 to 9, sometimes actually going until the 12 weeks, which is development of palatine shelves from maxillary processes elevate horizontally and fuse. So mandibular growth and tongue position is critical for elevation. And ossification after that, it's actually also related. So cleft of the secondary palate is lack of fusion of palatal shelves. Facial clefts are also starting at this time, Robin sequence also. And then we have skeletal development, which will be cartilaginous neurocranium, cranial base, and membranosus neurocranium flat bones. Then prenatal screening, CVS and amniocentesis and ultrasound are actually at this time. So based on the structures, those which we will see, for example, on this slide on the right side, when we see 6 weeks embryo and 7 weeks embryo, we can project these typical facial cleft lip and palate, cleft lip and alveolus and isolated cleft palate nicely with processes during embryonic development. But we have some clefts which are also belonging to these isolated anomalies. We call them atypical facial cleft or sometimes Tessier facial cleft because plastic surgeon, French plastic surgeon Paul Tessier actually introduced their classification diagnostics. So these atypical facial clefts are based on more neuroembryology, on developmental fields. And developmental fields are distinct neurovascular pedicles, which have blood supply and neuro supplies as well. And based on actually a kind of disturbance that pedicle may actually lead to different facial cleft. So as you can see on the pictures which we have on the slide, on the lower part of the slide, we have very bizarre sometimes type of clefting. And again, on the chart which we have here, we see classification which Paul Tessier introduced on bone, bony cleft and soft tissue clefts. And he actually number them according to the position from 0 to 14. And if we match this to the developmental field, these pedicles, then we can distinguish 5 types. Those invisible ones, which we can observe on Tessier number 3, when we have actually missing part of that. Okay, so then we can have dwarfs when field is present, but it's abnormally small. And we can see that when we have diffusion vomer and in isolated cleft palate as well. And then we have the third type, which is dysfunctional family. And these actually may lead to explanation of what we seeing in lateral facial cleft. There is a, a fusion failure of border zone between certain pedicles. And then we have giant, another type, which will be larger than normal, and again pushing adjacent field aside, and this will be hypothyroidism. And then finally, most severe one will be leaky field seen between normally developed zone, and this will be actually explaining encephalocele. The last topic in the first part of our lectures will be prevalence of cleft lip and palate. Let's look first at word data. About 140 million babies are born every year in the world. It means about 4 births per second. How is it with babies with birth defects? More than 8 million babies worldwide are born with a serious birth defects each year. And then with cleft or another craniofacial anomaly, 200,000, from 200,000 to 150,000 each year worldwide. What does it mean? About 550 to 660 each day, and each hour about 23 to 25. So in average, 1 in every 700 to 1,000 newborn is born with cleft lip and palate or another craniofacial anomaly. We have 7,500 each year in the United States, about 36,000 each year in India. So in other words, every 2.5 minutes, a child with a cleft is born somewhere in this world. So let's summarize important point. We hear 2 terms, prevalence and incidence. Prevalence is a measure of the frequency of a disease or health condition in a population at a particular point of time. You may hear birth prevalence. It means birth during the birth. Incidence is a measure of the number of newly diagnosed cases with a particular time period. So we may say incidence during year 2000, during period of 2000, from 2000 to 2025. Out of 100 of malformed conceptuses, will 90% gone to spontaneous abortion. It will be these late menses and so. 8 of these will end with congenital anomalies at birth. And then 2 will actually be diagnosed later in life with congenital anomalies. So out of all birth defects, 35% are craniofacial and orofacial anomalies. Out of these, 80% are orofacial clefts. So orofacial clefts are most common anomalies of orofacial region. In California, we have 1 in 560 in total California births. Varies in different studies, but it includes syndromic and non-syndromic cases altogether. In United States, again, as I mentioned, every year we have 7,500 children born with cleft lip and palate, about 21 per day. So 14 cleft lip and palate and 7 with cleft palate. Non-syndromic orofacial cleft vary from 1 in 350 in 1 in 2000 in different parts of the world. Non-syndromic orofacial cleft in California will be 1 in 920 births. And it's again based on our studies of a large population over 2.5 million births in California. Most frequent orofacial clefts are in least developed and less developed countries, where is poor nutrition and unclean living condition. So general estimate is 1 person with a cleft live in this world in each 1,000 inhabitants. And then on the right side, you can see some details which we have in United States and Central Europe, different type of the cleft. So again, in different population, it's very much influenced by ethnicity, sex, type, and severity of clefting. In the United States and Central Europe, most common type is unilateral cleft lip with or without cleft palate in males. It will be 0.6 per thousand or 1 in 1,667. Females with unilateral cleft will be 1 in 3,300. Males with bilateral cleft will be 1 in 5,000, and females with bilateral cleft 1 in 10,000. Any type of cleft with no sex differences will be approximately 1.2 per thousand or 1 in 833 in US and Central Europe in average. So these are most important information about prevalence. Again, with some more details you can find in the literature, and we will be mentioning them in following parts of the lecture as well. So we finished the first part of our lecture, and you should have enough knowledge about classification, diagnostics, craniofacial embryology, and prevalence of cleft lip and palate and craniofacial anomalies. The second part will be focused on etiology and heritability, and also on risk of occurrence and recurrence. So thank you very much for your attention, and get ready for a second part of our lecture.